community initiatives and program building are focused on global health and education. Dr. Poole produced an award-winning documentary titled Mountains of Hope about the challenges of HIV in Lesotho. She created an ultrasound technique with colleagues at the University of Cape Town to evaluate mediastinal lymphadenopathy in children as a marker of pulmonary tuberculosis. Her research in Malawi includes training the local clinicians in point-of-care ultrasound as a tool in the diagnosis of extrapulmonary tuberculosis. She has conducted collaborative projects with oncologic surgeons in South Africa with the goal of implementing diagnostic breast ultrasound to assist in triaging palpable breast masses. She published collaborative projects with infectious disease specialists in Brazil on imaging of Zika infected patients. Dr. Poole created one of the first formalized 4-year global health curricula for radiology residents at UCLA. She is an operational and management team leader for RAD-AID International and an international outreach committee member for the Society of Breast Imaging. Dr. Poole is an invited lecturer for the World Health Organization on the topics of breast ultrasound and ultrasound of infectious diseases. She is currently working with the Lancet Commission on Global Diagnostics to elevate the level of diagnostic capacity in low and middle income countries. Dr. Kerali Poole will talk on breast imaging basic BioRADS. And I'm requesting Dr. Kerali Poole, please, to start her presentation.
Okay, I'm gonna stop my video, but can everyone see my screen or no?
It's not visible yet.
Okay. Share screen. Okay, there you go. This one. Share. Is that visible?
Yes.
Yes, okay. Let me just hide this. Can you guys see that very large?
Yes.
Okay, great. Okay, so I'm gonna start now. Okay, hi, so thank you for the warm welcome. Yeah, my name is Carly Poole. I'm a breast imager in Los Angeles. And I do the majority of my work. I do conduct a lot of breast and pediatric imaging, but half the time I'm also doing my global health research. Thank you very much, and I hope you guys are all doing okay during this pandemic. Hopefully it'll be over within the next 6 months to a year, although it'll linger with us for a while, but just stay safe. Okay, so let's talk about basic BioRADS, and I'm gonna review just basic BioRADS. If you have any questions, you can always email me. Here's my Twitter, and you can ask the moderators for my email if you have any specific questions. And this is my Twitter account, Dr. KL Poole, but again, you can ask for my email from the moderators. Sorry, okay. Okay, so doctors use a standard system to describe mammography findings and results. This system, called the BioRADS Imaging Reporting and Data System, or also called BioRADS, it sorts the results into categories listed 0 through 6. So some of this might be basic, but I'm gonna go through some of the more specifics. By sorting the results into these categories, doctors can describe what they find on mammogram using the same words and terms. So if one patient goes to one clinic and then another clinic, we all communicate in the same language. So this is what the categories are, 0 through 6, 1 being negative, 2 being benign, 3 probably benign, meaning follow-up, 4 suspicious, 5 highly suggestive of malignancy, and 6 known malignancy. So you categorize each lesion into these 6 categories, or breast actually, but some people categorize each lesion as well. So category 1 means, oh, it's nothing, it's absolutely nothing, I don't see anything. Category 2 is also, this is nothing, this is a simple cyst, or this is a known fibroadenoma, don't worry about it. And category 3 is probably benign, which means you want to follow it. We usually do a 6-month follow-up, but it's okay to do any other type of follow-up. If you think, if it's maybe an infection and it's going away with antibiotics, you can follow it up in a couple months to make sure it wasn't anything else other than an infection. And then category 4 is a very strange category because you internally think it's between 2 and 95% suspicion of malignancy. So then what we did was we broke that down into more categories so that you could really tell your referring clinicians what your feeling is inside about how suspicious it is. So a category 4A, your suspicion is between 2 and 10%. 4B is 10 to 50%, and 4C is 50 to 95% suspicious. Now, I will go through how we categorize each of these, and it actually has to do with research and the positive predictive value of what you're actually giving each lesion. So it can be a feeling inside, oh, this probably looks like a 4A, but it actually could also be very mechanical, and you can use data to categorize it as 4A, B, and C, and we'll go over that too. And category 5 is greater than 95% malignancy, and category 6 is I've already biopsied this, it's cancer. Again, the categories are 0, 1, 2, you don't do anything. 3, you give a short interval follow-up. 4, we biopsy, okay? And 5, we biopsy. And 6, it needs to come out or get chemo or radiation. And I saw plastic surgeries here, which is a very important part of our work. So let's just talk about breast density for a moment. So breast density decreases with increasing age, postmenopausal status, and tamoxifen use. So women on estrogen replacement therapy and those with higher serum estrogen concentrations, they tend to have denser breasts. So when women lose weight also, the ratio of fibroglandular tissue to fat increases, therefore leading to denser breasts. One of the main reasons quoted for the increased risk from dense breasts is secondary to masking of the breast cancer on screening mammography. So you can see here on the left-hand side of the screen, the fatty breast, and on the far right, an extremely dense breast. As you can see, it is very difficult to pick up some small cancers in the extremely dense breast. The small cancers might be masked. That's the word that we use, masked. So therefore, we can't see it. Now, masking was decreased when radiologists went from screen film to digital mammography. And likely even more masking, less masking, occurs when we implemented 3D mammography. However, this is not the only reason that dense breasts equals higher risk. One theory is that the glands, they tend to be made up of relatively active dividing cells, which can mutate and become cancerous. So the more glandular tissue, the greater the risk. A second theory is that the local environment around the glands may produce certain growth hormones that stimulate cells to divide. And this seems to be more true for fibrous tissue than for fatty tissue. So how much is your risk increased? Well, this is a very controversial topic. Some say breast cancer of an extremely dense breast can be increased 4 to 6 times that of a fatty breast. But wait, I think that is just some researchers. And I usually quote the number, you have about a relative risk of 2 of your extremely dense versus not, because we haven't 100% proved that yet. So 2 is a good number to quote. You have a 2-time risk of your extreme dense versus your non-extreme dense. So supplemental screening with breast ultrasound in addition to mammography should be considered. And this is actually implemented here in the United States. And there is a mandate for many of the health insurance companies to pay for ultrasound. I think it just depends on the country and the amount of resources. So as you guys know, I do a lot of global health. And so if there's a country that cannot afford mammography, let's just say, versus ultrasound, you do the best you can. Here,
Dr. Pool.
yes, sorry, go on. Hello?
Yeah, we can hear you now.
Okay. Okay, so, all right, so these are the 4 categories of breast density: almost entirely fatty, scattered fibroglandular, heterogeneously dense, and extremely dense. Okay, so let's move on to how we describe masses found on mammography. So we have 3 different categories: shape, margin, and density. The most important descriptions are shape and margin. A mass is a 3-dimensional it's a three-dimensional object that occupies a space, and you should be able to see it on two different projections. So the first shape that we will describe is oval. An oval mass is elliptical or egg-shaped. Oftentimes, these can be cysts or complicated cysts, but sometimes they can actually be cancer, so you sometimes have to work them up. A round mass, which is often classically a cyst, and this is an example of a round mass, it's a ball-shaped, circular, or globular. An irregular mass, this shape of a mass is not round or oval, and this descriptor usually describes a cancer. Finally, circumscribed, which is the margin, okay? The margin of a circumscribed mass is sharply demarcated with abrupt transitions. So oftentimes these can be cysts, and this one is an example of milk of calcium because you could see that it's a cyst with a little bit of calcium layering in that cyst, and we'll talk about that later. Finally, obscured is another type of margin example, and obscured can be a scary mass, and oftentimes it is a cancer, and it's used when the margin of the mass is circumscribed, but that greater than 25% of the mass is hidden. Okay, and a microlobulated mass is characterized by short cycle undulations, and this description is usually used for something that's suspicious. Although I will say that you can have fibroadenomas and apocrine metaplasia, which are both benign, have microlobulated margins. And finally, this is the most scary one, which is a margin that is indistinct. Oh, sorry, and spiculated is also very scary. So let's talk about density. Now, density does not necessarily mean cancer. Like, if you say something has high density, yes, it's more likely to be cancer, but it's, you know, the margins and the shape are actually more descriptive of knowing if it's going to be a cancer. So high density means the X-ray attenuation of the mass is greater than the expected attenuation of the surrounding fibroglandular tissue. So this here is an example of a high density mass and an invasive cancer. And here are some examples of high density masses. You can see invasive ductal carcinoma, tubular, mucinous, all cancers, medullary, invasive lobular. You know, one could argue that that invasive lobular on the corner there is equal density and not high density. So here's an example of equal density, and this one is just isodense to the surrounding fibroglandular tissue. And this is low density. So low density is the X-ray attenuation of the mass is less than the expected attenuation of the fibroglandular tissue. A low density mass is often sort of fat, or it could be fat implants, which they used to do back in the day. A fat containing mass. So this includes a lipoma here you see, and also this is scarring down after removal of a cancer, which we'll talk about more. Okay, so let's move on to calcifications. We have typically benign, suspicious, and the distribution. So calcifications are assessed as benign at mammography, that are assessed as benign, are typically larger, coarser, with smooth margins, and they're more easily seen than the malignant calcifications, which is unfortunate. Calcifications associated with malignancy are usually very small and often require the use of magnification views. So that means your tech has to change what kind of device they use on the machine, and you got to get magnification views. When a specific typically benign etiology cannot be obsessed, we need to get magnification views on these calcifications. So here's a typically benign calcification. It's a skin calcification. You can get tangential views to prove that it's on the skin, but we'll have another speaker, and skin calcifications are very easily seen on tomosynthesis. So these are often found on older ladies, and sometimes young ladies, but vascular calcifications, as you can see, they're like train tracks. So they're not scary calcifications. These are tubular, that you could see both sides of the vessels. Coarse popcorn-like calcifications are greater than 2 to 3 millimeters, and they're often produced by involuting these are all involuting fibroadenomas. So you have a lot of fibroadenomas in one's breast, you'll see quite a few of these in a woman's breast. And everyone has seen these in sometimes older ladies. These are these are called large rod-like, and they're greater than 0.5 millimeters. But don't remember not to get satisfaction of search in these ladies, because as you can see on the bottom left of your screen, there's a group of DCIS calcifications. Those are different than those rod-like calcifications. Okay, so round calcifications, these are, they can be multiple. They're smaller, when they're smaller than 0.5 millimeters, they can also be called punctate. And they're considered benign when they are diffuse and when they're small, okay, so less than 1 millimeter. And they're frequently associated with acini of the lobules. Let's go to rim calcification. These are very easy to see. They're usually oil cysts, and they're thin rims and calcium deposits around the rim of the oil cyst, so that's typically benign. And then expected post-treatment findings also have calcifications. So fat necrosis has rim or coarse calcifications, and they also have variable appearance on ultrasound. So sometimes the ultrasound look of fat necrosis can be very scary, as you can see on the bottom, but on the top, they're very classic with these coarse rim calcifications. And then we know it's fat necrosis, and often getting a patient's history, you'll know. Also, again, don't get satisfaction of search. I mean, just last week, I looked at a case that had a little growing mass next to the fat necrosis. So, you know, just don't remember, you can get masses. They'll look a little denser, they'll look different, and just please try not to get satisfaction of search with the fat necrosis. Again, typically benign dystrophic calcifications. These sometimes come from old surgeries or old sutures being placed. And here are some expected post-treatment imaging findings. So a hematoma or seroma, you could see 2013, 2014, and then the fat necrosis in 2015 with the nice, round, perfect fat necrosis with coarse calcification, excuse me. Okay, so milk of calcium, as you can see on the cranial view, they're very smudgy. And then when you go to the medial lateral view, they layer and look like teacups. These you can let go. They can be scary looking, but if you do get your cranial caudal and you see smudgy in the same area as the medial lateral, which is teacup form, you can let it go, and they're just benign milk of calcium. If you are nervous, you can actually get an ultrasound, and sometimes what I do is, if I am nervous, I try to find little clusters of cysts to prove that yes, there's probably little clusters of cysts creating that milk of calcium. Okay, next, typically benign, which are just sutures, easy enough. Okay, so here is some data here, which I was trying to describe before, to allow you to place things into different categories if you're suspicious. So the morphology is the best type of descriptor to place it into which how suspicious you are. So these are the pivotal articles that were published: amorphous, coarse, heterogeneous, fine, pleomorphic, and the most scary, fine linear or fine linear branching. Please put your eyes to the right-hand side of the screen underneath total. You'll see fine linear and fine linear branching, 70% of them ended up being cancer. So that's why fine linear branching, which we'll describe a little bit in a second, is the most suspicious. Okay, so suspicious morphology. Well, amorphous is suspicious. So what is amorphous? These are so small and or hazy in appearance that a more specific shape couldn't be given. So on the top left corner, these are amorphous. These are given a positive predictive value of 20%. So that would put it in a category 4B. Remember, 4A is between 2 and 10%, and 4B is between 10 and 50%. So 20% positive predictive value is a 4B. However, if they are segmental, then you would pop it up into a positive predictive value of 62%. So that puts you into a category of 4C. So you can tell the patient and the clinician, this is a little bit more suspicious than what we thought because it's segmental. So coarse, heterogeneous, these are irregular, conspicuous calcifications that are between 0.5 and 1 millimeter, and they tend to coalesce. And a single group of coarse heterogeneous calcifications has a positive predictive value of 15%, puts it into a category 4B. Finally, fine pleomorphic calcifications. These are less than 0.5 millimeter in diameter, and they have a higher positive predictive value just by themselves, 29%. And then fine linear branching have the highest positive predictive value of 70%, which is a 4C. Okay, so you can see the suspicion goes up from benign to malignant, going from amorphous, coarse heterogeneous, fine pleomorphic, fine linear to fine branching. Okay, so the distribution. So again, here's what we're getting. What is the likelihood that which distribution is cancer? So if you go to the right-hand side of your screen and look at the total, segmental is the most scary. So 29 out of 47 of them were actually cancer. So calcifications that are diffuse are benign. These calcifications are scattered randomly throughout the breast, and they're often bilateral. So regional can come from things like fat necrosis, or, you know, also regional can be scary ones too, like the bottom. This is used for numerous calcifications that occupy greater than 2 centimeters, but they're not conforming to a duct. And then a group of calcification is greater than 5 calcifications that are within 1 centimeter of each other, but they are less than 2. So basically, so they're less than 2, but as we quoted before, the regional is greater than 2. And then linear is sort of in a linear pattern, which is a scary type of calcification because we think it's within the duct, so it's probably going to be positive. And then segmental is the most suspicious. These calcifications are in a distribution of concern because they suggest that they deposit in the duct or ducts with branches. So these are quite scary if you see them. Okay, so architectural distortions. These are and associated features. So let's move on and discuss these, and we're almost done. I'm sorry if I'm taking up too much time. Architectural distortion means the parenchyma is distorted with no definite visible mass. And this can be caused by lots of things, trauma, surgery, but it also can be caused by things like radial scar, which actually we remove because it's a slightly high risk lesion. It can be caused by invasive lobular carcinoma, and it can be caused by invasive ductal carcinomas. So in terms of just the BioRADS scores, the BioRADS, we have the word asymmetry. So there's 2 different sort of asymmetries, like pathways. One is just a simple asymmetry, which we can only see on one view. And then a focal asymmetry we can see on 2 views. So I'm going to go through the asymmetries because I think these are important for you guys. So Sickles, who's the very famous UCSF breast radiologist, wrote a paper saying that if an asymmetry is seen on only one view, it is very likely that is going to be just superimposing tissue. So out of 2,000 asymmetries, only 1,600 were not cancer. Only 36 cancers were found. So it's a very low risk that a single asymmetry, meaning only seen on one view, is actually going to be cancer. So it's just a fibroglandular tissue projected on one view. So, excuse me. Okay. So global asymmetries can be a normal variant, and only 1.4 of them are malignant, but they were all palpable. So that's according to Copans, who wrote a paper in 1989. So the global asymmetry that's palpable could be pseudo-orange. You have to look at the patient. But then there's other global asymmetries where women just have more dense breasts in one breast than the other. So if you see sort of trabecular thickening or pseudo-orange, you'll know that it's diffuse lymphatic invasion and probably inflammatory breast cancer. So global asymmetry can actually be super scary, or it could be just benign. So you really have to look at the patient, and you'll know if it's infiltrating lobular, you'll know if it's an inflammatory breast cancer if you look at the patient. And then a focal asymmetry differs from a global asymmetry because it just occupies one quadrant of the breast. Robust clinical research has said that only 0.5 to 1% likelihood of malignancy for a solitary focal asymmetry identified at screening. So you can actually give this a BioRADS 3 and just follow it. And then a developing asymmetry is actually a little bit more scary. So developing asymmetry should be given a BioRADS 4. You should try to find it on ultrasound and see if you can biopsy under ultrasound. And if you can't, then you should probably biopsy under stereotactic guidance. Developing asymmetries are scary because they're actually probably something going on in the underlying breast. If you've seen it for 2 to 3 years on prior imaging, you can leave it alone. And so developing asymmetries, just watch out for. It's something that we need to train our eye for. And then an intramammary lymph node is okay if you have a fatty hilum and if the cortex is around 3 millimeters, and also if it's been stable for many years. And skin lesions we'll probably talk about with tomosynthesis, but they're very easy to see on tomosynthesis, and you'll see the nice air surrounding a skin lesion. And also you can get your tech to just put a little circle or a BB on it to make sure it's a skin lesion. Finally, a solitary dilated duct. This has been an area of much concern, even though it probably shouldn't be. One paper showed that that you should biopsy it if it hasn't been stable for many years, because there is a 2% chance or greater than 2% chance of DCIS or papilloma being found. Now, if it's a very older lady, you can make your own clinical assessment if you want to go ahead and biopsy that or just leave it alone. Okay, so some of these other associating features. So this is a skin retraction. So skin retraction is the skin is being pulled abnormally by the breast cancer. And let's be sure we understand inverted nipple, that can happen. Women have inverted nipples. That's not scary. It's if it's new, it's changed, and you see a mass behind it. So remember, nipple retraction versus inverted nipple can be normal, okay? And then skin thickening, which could be caused by radiation or CHF, which is the patient on the right, congestive heart failure, excuse me. But it also could be caused by Poudre Orange as well. Ooh, sorry. And here we see there is trabecular thickening with fibrous septa of the breast, and that was a post-radiation patient. And then again, that's post-surgical, so again, skin thickening. And all of us have seen, bilateral enlarged, axillary lymph nodes, and this can be caused by a multitude of things, including HIV, TB, CLL, rheumatoid arthritis. Now, if it's unilateral, you might want to biopsy. If it's bilateral, you can biopsy. It'll probably come back reactive, but you should just get them worked up by their physician of what's causing the bilateral adenopathy. And architectural distortion on the left, this was actually invasive lobular, and on the right is radial scar. Excuse me. And then calcifications can be included with descriptors. So here was a patient who had post-surgical changes and she had calcifications developing. Sorry, finally, I'm just trying to rush through this. The locations of lesions should be always described. You want to give the laterality, which is what side it is, the right side, the quadrant and the clock face. Upper out of quadrant is something that you could say. The clock face location, which is, let's say, 10 o'clock. The depth of the lesion, which is anterior third. And then how many centimeters from the nipple, which would be an example of 3 centimeters from the nipple. This just helps everyone speak the same language. All right, and I'm done. So